This video demonstrates low-lid blepharoplasty. In younger patients under 50, fat prolapse without significant skin excess may be better managed with transconjunctival approach. However, in this case, a conservative transcutaneous approach was chosen due to mild skin redundancy. The patient is examined in both open and closed eye position. Gentle superior displacement of the upper lid highlights the prolapse of the orbital fat. Operacaine drops are installed. The lower eyelid skin is then cleansed with alcohol swab to improve surgical marking accuracy. Subciliary markings are made approximately 1 to 2 millimeters below the lash line, extending from punctum to the lateral canthus and then slightly laterally and inferiorly along a natural skin crease. A pinch technique is used to assess the amount of redundant skin. Skin excision is planned conservatively, especially medially, to avoid postoperative complications such as lid retraction. Local anesthesia is infiltrated carefully into the lower lid. Silk traction suture is passed through the gray line. The skin incision is made using Colorado and 15 number blade. The skin flap is elevated and minimal skin excision is performed. Dissection proceeds to expose the orbital septum. The orbital septum is open and the herniated orbital pad fat are identified. Fat pads, medial, central, and lateral, are carefully evaluated. Excess fat is generally teased out, clamped, and conservatively excised. Hemostasis is achieved with cautery prior to releasing the pedicle. Care is taken throughout to identify and preserve the inferior oblique muscle between the medial and the central fat pads. A transcanthal canthopexy is performed to address the mild horizontal laxity and to provide additional low lid stability. This is achieved using 50 Vicryl sutures for deeper support and 60 Prolene for the precision fixation. To further refine the lateral contour and prevent dog ear formation, a small triangular segment of redundant lateral skin is conservatively excised. Skin closure is then completed with a continuous 6-0 or 7-0 Vicryl sutures using a smooth, tension-free approximation and optimal cosmetic outcome. The same procedure is repeated on the left side. The skin is excised using Colorado needle. The septum is opened using a blunt scissor. Care is taken to preserve the inferior oblique muscle between the medial and the central fat pads. The pad pads, medial, central, and lateral, are carefully evaluated. The medial, middle, and the lateral pad pads are addressed in the same controlled manner. Ensuring the hemostasis, the septum is tightened with the cautery. Lateral canthopexy is performed as on the right side. And the incision is closed with Vicryl suture. Final inspection confirms a good contour of the lower eyelid and with preservation of natural anatomy. Thank you for watching.